I choose a clinical case of this day, which is in my practice quite different from previous years, 10 years ago, when anti-angiogenic treatments arrived for clinical trials. So this is my case. So a male, 71 years old, living a little bit from Bordeaux. He has a post-medical history of cardiovascular problems, and the specific medical history starts in 2008 with some decrease in performance status and weight loss. As a workup found a right renal tumor, and the patients underwent a nephrectomy in April 2008. And it was a classical results with clear cell carcinoma, Fuhrman's grade 3, classified PT3, PN0, and R0. After surgery, his performance status increased to 90, and he had weight loss, but he came back to more normal weight, even he has lost 10 kilos. Sorry. So I received these patients in November 2009 because he had right iliac fossa pain, and he had some decrease in performance status, and the patients had pain asking for analgesics level 2 codeine-based treatment. And he suffered from some dyspepsia, and the biology was normal for MSKCC risk factors. Sorry. And here is a CT scan with major recurrence in the nephrectomy site and some direct invasions of liver. He didn't have other metastatic sites. So what was strategy? It's first line, it's clear cell component, and the patient has this high tumor burden. So the French and European guidelines at this time were sunitinib or interferon bevacizumab. He was classified in gross prognostic group, but the problem for him, it was an active man, he has symptoms due to pain. So the standard could have been sunitinib, could be efficient whatever sides, and can be rapidly efficient, and it's orally given. Interferon beva, same thing, but IV. And at the time, we had a trial with sunitinib and IMG 386. This patient was included in this study, so don't care about that. So the result will be presented by Michael, I think, as an ASCO, but we will concentrate in the sunitinib-based treatment. As I had these patients, and as we are doing everywhere, I inform the patients of the side effects, give him a preventive prescription, but I say to him, with your tumor burden, you may see some asthenia, and we will look at that. So we start at the standard dose. The good thing is that the pain decreased very rapidly after 2 weeks of treatment, but at the end of 2 cycles, he had some asthenia and fatigue and grade 3, and sometimes he was completely exhausted. He had weight loss like 10%, and he has other common symptoms, side effects, but that were grade 3. He had no major body change, whatever you can see here on urograms or renal functions. At the end of the 2 cycles, this patient had a CT scan. He has a tumor shrinkage of 10%, and with some tumor and major tumor necrosis. So we had some discussion at this point because he had suffered from grade 3, but I say to him, maybe it could be used for you to have a better tumor shrinkage, because if there is a relapse, it's better to be far from that and far some symptom. So we are going to add 2 cycles, 1 + 1 at 50 milligram, but if you experience too much grade 3 and mainly fatigue, we will see for decreasing the dose. And during cycles 3 and 4, no recurrence of metastatic pains, a major improvement in fatigue, and the weight loss was stabilized. And as you can see, the other side effects were only grade 1. He started to have a limited bilateral venous leg ulcer grade 1, and you will see it will be a problem afterwards. And we increase the tumor shrinkage to 18%, with still tumor necrosis that increased too. And we went to additional 2 cycles. But in few weeks, there were a change to the venous leg ulcer to grade 3, and had to stop the treatment during cycle 5 and AMG in the follow-up due to the concern on the clinical trials. It takes a long time to have resolutions. The patients had a PD 9 months after stopping sunitinib. I tried to restart sunitinib at 25 milligram, concerned by the leg ulcer, but he had recurrence, and the patients went for PD and died in early 2012, 26 months after starting the treatment. So What means high tumor burden? But we may have two types of patients with high tumor burden. It could be slowly progressive and no major impact, which was the case of my patients, and it could be rapidly progressive and usually major clinical impact, which was not this case. And we will be concerned, and I think it's important for decisions when you need for having a symptom control and you need to have any objective response, and the concern also is impact on toxicity due to the volume. At the time of decisions, I didn't have these recent publications done by the Cleveland Clinic groups and the Gustave Roussy Institute on the negative impact on prognosis due to high tumor burden. So efficacy, everybody knows that. We could be efficient with whatever the drugs that we may use, and what is important too, whatever the tumor burden, these drugs are efficient whatever the tumor size by brain. We may have some concern about interferon beta to be more active in lung, which is not the case. It's efficient everywhere. And we don't have information about different efficacy due to the volume. Here, from the two groups I present to you, these are publications by Cleveland Clinic Group and here from Gustave Institute. Here is the impact of the tumor burden on the PFS after given sunitinib, and you can see that if the disease is below the diaphragm, the PFS is worse, and if the total burden is more than 13 centimeters is worse, and in my patients it was the case, and we fit with that. The Gustave Institute proposed a more linear change, that meaning that if the tumor burden increased by 1 centimeter, the risk of progression is increased by 5%. And moreover, tumor burden could affect also overall survivals, and with different parameters in the univariate analysis, you can see that if you have more than 10 deposits, the overall survival is worse, and if you are below the diaphragm and the tumor size is bigger than 6.5 centimeters, it's also worse, and our patients were according to these publications. So there were different limits in the Gustave Institute's limits here, as you can see here, that may affect the overall survival. My patients were more in this series, but the overall survivors were longer, and what we expect to be that the tumor burden could be linked to the echo performance status and poor MSKCC score, meaning that when you have a high tumor burden, usually the echo performance status is low and the patient has a poor MSKCC score, which was not my case, so maybe why the overall survival was longer than that. We could be a little bit afraid about tumor lysis. I've never seen that in my patients, and it was not the case. It was reported here from some clinical case, major masses here, time with VEGF-ATK and major necrosis, and these patients are the known tumor lysis complications with hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia, and often acute renal failure. So, in real life, I think we are far from the tumor lysis syndrome, but clearly high tumor burden exposed to some degree of tumor cell death, especially for active drug, which is our case, and there is some kind of cytokine release that remind us of neoplastic symptoms with secretion of interleukin 6, and some impact on asthenia, fatigue, and biological parameters. And it's why I say in my practice it changed, because I have seen these patients with this clinical case in early time of expanded access program. Tumor hemorrhage or perforations is more a concern of size than volume here, and it's less frequent in RCC. So my conclusion is less frequent. I think there is no reason to change a similar approach for these patients that in first line, but what I should recommend is my take-home measures, closer follow-up, because you may have a too much rapid efficacy and you may discuss risk of toxicity. I may be challenged to use a less active drug, and sometimes I use observations. But you should also follow this patient, but because if it's initial aggressive disease, there is a risk of rapid PD. Thank you for your attention.